Today we are going to discuss about a congenital heart disease called atrial septal defect. So to know about this, you should know how your interatrial septum develops. So first, when we discuss about the development, by the 5th week of intrauterine life, the heart is present as a single chamber. Later on, your interatrial septum and your interventricular septum is formed and you have the valves which divides the heart into 4 chambers called your right atrium, right ventricle and left ventricle. So this is how the heart is going to be formed. So how this interatrial septum is formed is what we are going to discuss today. So first of all, while you have a heart as a single chamber, you have a part called as endocardial cushion. So this is called as endocardial cushion. So this is the one which is going to develop your tricuspid valve and also your mitral valve on either side. So this is what is going to form your atrioventricular valves. So what happens is your interventricular septum will grow towards this cushion, your interatrial septum also will grow towards this cushion, and finally you have this 4th chamber. So here, how your interatrial septum is going to be formed. So this is your primitive atrium. So from your primitive atrium, you're going to have a septum which is going to grow down, which is called as septum primum. So this is called as septum primum. So now this septum primum, as it grows towards this endocardial cushion, there is a defect in the lower part and this is called as a foramen primum. So why you should have this foramen primum? Because you know during intrauterine life, the blood from your right atrium is shunted towards the left atrium. So therefore for this you need an opening and that is served by your foramen primum. Now as the septum primum grows down further, it will close the foramen primum. Now once the foramen primum is closed, there is no opening for the blood to move from your right atrium to left atrium. So therefore nature has worked on this by doing a wonder, and that is by forming another foramen on the top which is called as foramen secondum, and this foramen primum will close now. So this is called as foramen secondum. Now as the septum primum grows down, the upper part degenerates and forms a foramen called foramen secondum. Now what is the purpose of this? This allows the blood to move from right atrium to left atrium. And this foramen primum is closed because of the growth of your septum primum towards endocardial cushion. Now what happens next is, you have another septum which develops on the right side. So here you have the septum primum with your foramen secondum, and this is going to be your septum primum in the lower part. So here you are going to have another septum which is going to develop on the right side, which is called as septum secondum. As it grows down, this will cover the foramen secondum. So this is called a septum secondum, which is going to cover your foramen secondum. But if this is covered, there should be an opening so that the blood from right atrium moves to left atrium. So how is that done? So this septum secondum, while developing by itself, will have a defect at the bottom which is called as foramen ovale. So because of this foramen ovale, the blood from the right atrium moves across this and then moves across the foramen secondum into the left atrium. So this is how the communication between your right atrium and left atrium happens during the intrauterine life. Now why communication happens from right to left? Because intrauterine life, the pressure in the right atrium is little higher than that in the left atrium. So blood moves from right to left. But once the baby is born, the pressure in the left atrium is going to increase. So once the baby is born, the pressure in the left atrium is going to increase. Now when the pressure in the left atrium increases, it is going to allow the blood to move from left to right side. So this is what is going to happen. And when we discuss about the atrial septum, I told you that you have the septum primum, here you have the foramen secondum, the septum primum which is attached with the endocardial cushion. And then here you have got the septum secondum which covers this foramen secondum, and then you have the foramen ovale which is again attached to this endocardial cushion. So this is how your interatrial septum is. Now this septum primum is very flappy in nature. It is very light. It can move. It is very flexible. So what happens is when the pressure in the left atrium increases after birth, the blood moves from the left side to the right side. So this will make this to attach with the septum secundum. So the septum primum now will attach with the septum secundum. This both will adhere to each other. And this will be closed. And this will be closed, which then forms fossa ovalis. So this now forms fossa ovalis. So now after birth, that is why there is no communication between your right and your left atrium. But when there is a defect in development of any of these parts, then the opening persists, the defect persists, and continuously there will be left to right shunt, which happens. So which is what we are going to discuss under atrial septal defect. So this atrial septal defect can be of three types. So the first one is Ostium primum atrial septal defect, second one is Ostium secundum atrial septal defect, and third one is Sinus venosus atrial septal defect. What is Ostium primum atrial septal defect? I told you when your heart is developing, especially with your interatrial septum, the first one to develop is your septum primum, which has to come down and it has to attach to the endocardial cushion above where you have this foramen primum. So only when this septum primum develops very good, this foramen primum can be closed. So if this septum primum is not developing, then this will not be closed, and therefore there can be continuous communication between your left and your right atrium. So this defect is called as Ostium primum atrial septal defect. Now what is the peculiarity of this defect? So first of all, it is present in the lower part closer to atrioventricular valves, and second, attaching this septum primum to endocardial cushion will also stimulate endocardial cushion to develop the valves very good. So it needs help of the septum primum so that the valves are developing very good. So when septum primum is not developing very good, what will happen to the development of the valves? Obviously it will be disturbed. So that is why people with Ostium primum atrial septal defect will also have problem with their tricuspid valve and also mitral valve. So the percentage of this atrial septal defect in patients is around 5%. So we have hardly 5% of patients presenting with this type of atrial septal defect. The second type we are going to discuss is about Ostium secundum atrial septal defect, which is the most common presentation. So 90% of atrial septal defect are Ostium secundum atrial septal defect. So what happens over here? Now while we discussed about the development, I told you once you have the septum primum which grows down, there is another defect called foramen secundum, which is on the top, which will then be covered by your septum secundum. Now when septum secundum is not growing down, when there is defect in the development of the septum secundum, then this defect, that is your foramen ovalis, is quite big, and you have this continuous communication which is happening. So therefore this type of defect, which is because of the decreased growth of your septum secundum, is called as Ostium secundum atrial septal defect. The next one you're going to discuss is about Sinus venosus atrial septal defect. Now what is Sinus venosus atrial septal defect? Now when we discuss about the interatrial septum, so you know here you're going to have your septum primum, here you're going to have your septum secundum. Along with this, you also have your superior vena cava, which is going to form the initial part of your interatrial septal development. So this very tiny part is formed by the place where your superior vena cava drains into right atrium. So therefore this initially forms the upper part of your interatrial septum. So when this is not developed completely, then again this results in opening, so there can be communication. So therefore this is called as Sinus venosus atrial septal defect. Now people with this defect will also have another problem. What is that? Now you have the lungs, you have the right lung and you have the left lung. And you know the pulmonary veins are going to drain. Now what happens over here is the right pulmonary vein will directly empty into the superior vena cava in these patients. So in these patients, the pulmonary veins can either open into superior vena cava or it can open into your right atrium directly. So what causes this atrial septal defect? So who are prone to develop this atrial septal defect? So usually it is associated with Mendelian inheritance, like diseases like your Down syndrome, Turner syndrome or Noonan syndrome is associated with atrial septal defect. Whenever there is mutation of the genes like GATA4 or NKX25 or TBX5, there can be atrial septal defect. So normally when we talk about this NKX25, so when there is mutation of this particular gene, then the person can have congenital heart disease, they can have atrioventricular blocks, and also they can have juvenile sudden cardiac death. So this can be associated with atrial septal defect and also tetralogy of Fallot with respect to congenital heart disease. Now next, when we talk about mutation of TBX5, now TBX5 mutation can result in a syndrome called as Holt-Oram syndrome. So it is called as Holt-Oram syndrome. This is also called as heart-hand syndrome. So here people will be having a congenital heart disease, they will have upper limb malformation and they will have dysrhythmia. And this congenital heart defect, 58% is ASD and the remaining 28% people, they can have ESD also associated. Apart from this, whenever mother is exposed to rubella infection or there is alcohol consumption during pregnancy, then the baby can have atrial septal defect. So what are the clinical features people present to you with? Initially, all the people with atrial septal defect are going to be asymptomatic. Now, especially if the defect is going to be less than 5 mm, whatever age of the patient is, they are going to be asymptomatic. But when the defect is going to be more than 5 to 10 mm, then the person becomes symptomatic, but that also will be in their late 30s to 40s. So it will be after 30s to 40s that they will develop symptom. Now what symptoms they develop or what problems they will present to you with? Now generally whenever there is atrial septal defect, there is going to be shunting of blood from left to right atrium. As the pressure in the left atrium is little higher after your birth, the blood is going to be shunted from left atrium to right atrium. So when the blood is shunted from left atrium to right atrium, the volume in your right atrium increases. Why? Because there is shunting of blood from left to right and there is also emptying of blood through your superior and inferior vena cava. So therefore the volume increases in your right atrium. When there is increase in volume in your right atrium, there is going to be eventually increase in volume in your right ventricle also. So when there is increase in volume in right ventricle, obviously in the pulmonary artery also there is going to be increase in the volume. But when this increase in volume reaches your capillaries, this can cause exudation of the fluid outside, so which has to be avoided. So what happens to compensate for this? There is vasoconstriction of your pulmonary arteries. So there is vasoconstriction of your pulmonary arteries and there is proliferation of smooth muscles of your pulmonary vessel, of your pulmonary artery. So therefore there is proliferation of your smooth muscle. And finally in the later stages, it can also cause obliteration or obstruction of your pulmonary artery. So all these together, it causes the pressure in the pulmonary artery to increase, which is called as pulmonary artery hypertension. Now, when there is pulmonary artery hypertension, the pressure over here is more. When the pressure over here is more, the pressure in the right ventricle is going to cause your right ventricle to undergo hypertrophy and dilation. which again is going to affect your right atrium to cause hypertrophy and dilation. So these patients can present to you with pulmonary artery hypertension, which can result in your right ventricular or right atrial hypertrophy and dilation. And finally, whenever this right atrium is going to dilate, is going to undergo hypertrophy, what happens to the current flow in this right atrium? It is disturbed. So when the current flow is disturbed, person can develop atrial fibrillation. So these people are more prone to develop atrial fibrillation. Now third, whenever this right ventricle is going to undergo hypertrophy, the right bundle branch which is going to go to right ventricle is going to be disturbed. So therefore these patients can have right bundle branch block also. Now finally, when the pressure is going to be too high in your right atrium, this will shunt back the blood from right atrium to left atrium. Now this shunting of blood from right to left is called as Eisenmenger syndrome. This is called as Eisenmenger syndrome, which is very important. This happens because of your right to left shunt. So these are the presentations how a person can come to you with. Now what are the signs you can elicit? Now the signs you can see are, first you're going to check for the right ventricular hypertrophy, which will be evident in your parasternal heave. So you can see parasternal heave because of right ventricular hypertrophy. Now second, when we discuss about heart sound, the first heart sound will be fine, so no problem. But what happens to second heart sound? Now normally your second heart sound has got two components. One is called as aortic component and the second one is called as the pulmonary component. So you have aortic component and pulmonary component. So first you get the aortic component and second you get the pulmonary component. Now in these diseases, when there is going to be more volume and pressure in right atrium, it is going to increase in right ventricle. So therefore it is going to take longer time to empty into the pulmonary artery. So therefore your P2, the pulmonary component, is going to appear little late. So therefore there is going to be a splitting of this heart sound. So there is going to be splitting of the heart sound. So therefore this gap between this A2 and P2 is going to be more. So it is going to cause the wide splitting of your second heart sound. But this duration between this A2 and P2 is going to be same. So therefore the splitting is typically a wide fixed splitting of second heart sound. So it is called as a wide fixed splitting of second heart sound. Now next, when you talk about the murmur over here, so here you can see that the blood flow in the pulmonary valve is going to go with increase in velocity, and similarly it is also going to be altered in your tricuspid valve. So therefore, because of the pulmonary valve, the component involved, you can have a mid-systolic flow murmur. So you can have mid-systolic murmur. Now when you talk about the disturbance in the tricuspid valve, so because of that it can cause mid-diastolic, so this can cause mid-diastolic rumbling type of a murmur. So it can cause mid-diastolic rumbling type of a murmur. So these are your auscultatory findings. So first of all, what are the signs you can see? You can see for the parasternal heave, because of the right ventricular hypertrophy, first heart sound is fine, it is fixed, but second heart sound is wide fixed splitting because of your A2 and P2 splitting. And next you can have the mid-systolic murmur and you can have the mid-diastolic rumbling murmur. Now what are the investigations you can opt for? So when we talk about the investigation, so basically the primary investigation you need to have is echo. because echo will tell you whether there is the right atrium dilation or hypertrophy, or right ventricle dilation or hypertrophy, whether there is pulmonary artery hypertension, atrial septal defect, what is the size, everything will be detected in your echo. And what is the condition of the valves, whether your mitral valve, tricuspid valve, pulmonary valve, everything is working fine. So all that will be obtained in your echo. So echo is the mainstay of investigation. The second one is MRI. So MRI again can tell you the detailings of your cardiac structure. And next, what is the role of ECG? So ECG will tell you whether there is this right ventricular hypertrophy, whether there is pulmonary artery hypertension. So all this your ECG will tell you. Chest X-ray again will tell you whether there is dilation of your right atrium or right ventricle or your pulmonary artery. So that will be obtained in your chest X-ray. Finally, your right heart catheterization will tell you the pulmonary artery pressure. Now, how do we treat these patients? So treatment is only for people whose defect is going to be for more than 5 mm or when they have a very significant left to right shunt. So treatment is surgical closure of the defect either by a patch of pericardium or prosthetic or percutaneous transcatheter device closure. Now these people, if they develop arrhythmia, then you have to put them on antiarrhythmic drugs. So you can give antiarrhythmic drugs. And you can also start people on anticoagulants if required. And whatever comorbidities the person has, you have to treat that also. If person has hypertension, you give antihypertensive, you treat that condition also. So this is how you treat people with atrial septal defect.